Hey, Rebecca.
Hi, Josh.
Ready to get going on part two?
Part two. This is my favorite part.
Is it?
Yes, I love talking about difficult airways.
Oh, good. All right. Well, let's get started.
We're going to start with talking about why airways are difficult. And the first category is the anatomically difficult airway. And they kind of define difficult airway as a scenario where trained provider anticipates or encounters challenges with either mask ventilation, tracheal intubation, supraglottic device, or they they just can't manage or improve the patient's presentation. And so there are four mnemonics that we're going to talk about that all apply to the anatomical difficult airway. And
One thing they they say in the difficult airway book that we use, emergency airway management.
yeah, the Walls manual sometimes.
Yeah. Is because it's to physicians, in hospitals. Not, I don't want to say mainly, but in large part. And but there is the section on pre-hospital,
Yes.
and they say every airway pre-hospital can just assume to be a difficult airway. Not
Yes.
just because of the physiology or the anatomy, but also the environment, right?
Yes.
The resources that you have. So really pre-hospital stuff, we do assess for difficult airway, right? But just they're all difficult airway.
And this, as we get into these mnemonics, I know that EMS, there's a lot of mnemonics that we do this in EMS to try to offload our cognitive strain when we're under stress. But these, you should be applying these to your patient before you have an airway issue. So every patient you go on, ask yourself some questions about what would happen if we need to manage this patient's airway. So the first mnemonic, Roman, applies to difficult BVM, and these are the things we look at in our patients that might indicate we're going to have a hard time just BVMing this patient.
Big thing with this, if you are about to RSI and they are breathing and you're taking away their ability to breathe and you haven't really done a good assessment, can we even bag them?
Yeah, that's how we are going to lose RSI as a skill. So the first one, R, is for radiation or resistance to ventilation. This is harder sometimes to see if you're not really looking, but the tissue is stiff. If they've had radiation on their chest wall, they'll have a restrictive issue because their chest wall doesn't expand. Their neck might not be mobile. They might have issues with their jaw or their structures inside their mouth if they've had radiation. So be aware of that. O is obstruction, or
O is for oh my gosh. Sorry.
obesity. Obstruction meaning like angioedema, a mass, if they have a tumor, Ludwig's angina.
That's not the same as
Angina of the chest. It's different, weirdly enough. Obstructive sleep apnea.
Do we say what it is anywhere?
Not
Ludwig's?
in this one.
Okay. It is basically the under their tongue and everything is all full of swelling, so there's nowhere to displace the tongue.
Yes. And often it's related to a tooth problem, but it can be other things. So that's if you saw this patient that you came in and she was saying, I feel like I can't breathe.
No kidding.
Recognize
I can't. Well, never mind.
that you're going to have a lot of obstacles in making sure this patient can oxygenate. And it's something that you should be hyper aware of and be ready with a plan. The M is for Malampati, male or mask seal. And mask seal is beards. That's a good part of it. The Malampati you can do to assess a patient if they're conscious and obeying your commands. We're going to talk about that a little bit later. But male patients have more facial hair, sometimes have their structure of their face can be such that they might have a difficult time. But that's M. A is for age. This is This is me right before I go to bed.
That's you at the AC/DC concert you're going to this summer with your boys?
Yeah, I'm going to fit right in. Like, people will be like, oh, yeah. Hell yeah. I actually did go to AC/DC back in the 80s in Salt Lake. So it'll be like coming full circle. But people who are older.
Isn't that one of the members of the band actually a recent photo of them? Is that Angus? Angus.
Yeah, maybe. But older people, what happens to us, I consider myself part of this group, is
You're barely 50.
You lose volume in your face.
The older you get, old just gets pushed off further and further.
I'm not that old.
50 used to be old, not anymore.
But your volume in your face, you lose that. You lose muscle structure.
That's funny. I feel like my face has gotten fatter as I get older.
I feel like I'm turning into the Crypt Keeper. If you remember that old Tales
from the Crypt.
Now, like everyone listening, they're so young, they're going to have to Google that and find out.
Google Tales from the Crypt.
Like crazy, weird puppet. Anyway, so just be aware that our older patients, not only do they have a different facial structure, but they have sometimes like partials or dentures or things in their mouth that could create another problem. And then lastly, no teeth. And
which actually the teeth are like scaffolding.
Yes.
And so if you do have someone you're intubating, sometimes it's better off to leave their dentures in
if they're
they have
secure,
them, while you mask them.
Mm-hmm.
And then if you need to, it gives you substance to seal against, but and then you can take it out when you actually do intubate.
I wish I could say this was only the elderly population, but I've been on a number of patients much younger than me that don't have teeth, or they only have like 2 teeth in the front.
Well, you live in Payson, so
I'm not saying it was here.
Oh.
I'm just saying that this is not just an elderly population problem. And when they don't have teeth, they kind of cave in, and their cheeks will cave in, and you won't be able to seal that mask at all. And also, if they've gone for some time without teeth, their jawbone kind of deteriorates where their teeth used to sit. So they kind of overclose their mouth, so to speak. So it's
like this guy?
Yeah, just like that. And just keep that in mind. That's going to be a difficult BVM. Yeah. All right. So now the next acronym that we're going to talk about, we have a slide for each of these, because this is difficult laryngoscopy, and
you'll hear this over and over and over. And lemon.
And this is what they offer in the Walls manual. This is why we're using this. You will hear one that's Heaven, very similar. They both kind of cover the same things. So in our lemon laryngoscopy acronym, the first thing we need to do is look externally. Look for signs of a difficult intubation. And this is by your gestalt. This is something that you're like, oh, I do this when I'm standing in the grocery store line, and I look at people's face and I look at their side profile, and I kind of think, how would they be to intubate? For example, the woman in this picture, she has a very short mandible. Her area for displacing her tongue is reduced. So she potentially would be difficult. Now, I've seen patients that have this, and they were not difficult. They were slick. So
that's one of the things about this. Like, we talk about this, but sometimes they'll meet the criteria for a difficult airway using lemons, and they're great.
They're great.
And sometimes the opposite's true.
They look great.
They look great, and they're very difficult.
So this is
very
you
subjective. Trying
to prepare. But and by no means do we mean this doesn't apply. Like, you should be using this, but just know we're planning for the worst here. So here's another one. This guy, he has less space. He's got more tissue there to manipulate.
Looks like he'd talk a little bit like this.
Yeah, you don't
He's got
know.
some jowls there.
But
that's how I picture him.
That's going to be, and all the tissue on their neck. Like, here's another one. Like,
that looks like my cousin Carl. That might be my cousin Carl.
All the references for these photos are at the end of the slides.
The name and phone number
No,
of each person.
but
That's Carl.
you're going to have a lot of tissue to lift out of the way. And laryngoscopy is not about like, oh, I'm so strong. I'm gonna, like, it shouldn't take that much effort to move the tissue. But some of these people, he's got a short chin and a lot of tissue. So consider that might be difficult. The E in the lemon mnemonic is for evaluating the 3-3-2 rule. And if you've not heard this, you need to know that 3-3-2 is actually, they've done research, and it was a provider here in Utah that works up in Salt Lake County in those hospitals. He was on this. He sent me his paper, which I thought was fun. But the 3-3-2 is one of the best predictors in the field. And so that means, can they open their mouth? And it should be their fingers. Can they fit 3 fingers in their open mouth? Can you do that?
Oh. I got 4.
If only we have video right now. And then 3 fingers from their chin to where their neck.
So you mentioned it, the 3 fingers in their mouth. Okay, how wide does their mouth open? That's what you're looking for.
Yes, you're looking at the distance there.
Now, under the chin, you're looking for...
It's literally the mentum to the hyoid is what we're looking for. But that's your space to displace the tissue in their mouth, the tongue primarily. So if they don't have that, you're going to have you've got nowhere to put it. It's just not going to get out of your way is what you should be thinking. And then the 2 is from where your hyoid to...
What's that angle called? It's called the...
Well, this one's hyoid mental. And I think this is
not thiomental. Hyothyroid. And what are we looking at? What's that telling us?
So when you're looking at the 2 or the hyothyroid distance, they need at least 2 of their fingers distance, or you're going to be super anterior. It means you're going to have to look around the corner.
Around the corner. So especially with direct laryngoscopy, very difficult.
Very difficult. If you have a hyperangulated blade, that would be my first choice if I have someone with that short distance, because I've got to get around that corner to see. So that's the 3-3-2. All right. The M in our lemon mnemonic is the Malampati. And the Malampati, you have to kind of have them sitting up, facing you, obeying your commands to do this. You're opening their mouth, having them stick out their tongue, and oftentimes they'll just have them lean forward into it. They will have them lean forward, but you're checking to see if you can see their uvula. And
not to be confused with the vulva.
Oh gosh, no.
Which I asked orifice. In paramedic school. Mind you, I had no medical experience when I was lucky to get into paramedic school. I raised my hand. And I was a young single, like 20-something. I think I was 22, 23. What's the vulva for? And everyone busts up, and I'm like, the little thing that hangs in the back of your throat. You mean the uvula?
I don't even know where to go with that.
Okay. We don't need to go anywhere.
I will say that a lot of the patients that I end up managing their airway, I would not be able, they would not be able to do this for me. This would be someone I'm going to consider RSI, so I need to assess this right now. If you cannot see their uvula, odds are you're going to have a harder time.
Again, that's telling you how much space you have to work with.
It's all about manipulating that tissue out of your way. So that's the Malampati.
All of my kids, when they were little kids, maybe not all of them, but I remember my daughter particularly, she was going, and I could see her epiglottis poking up from behind her tongue. And then I've looked at other kids, and I don't know if it was just the random kids I chose, but their epiglottis was right there.
I don't know what that is. I've never
Not that
noticed
that's the uvula, but talk about a good malampati. You look in their mouth and you see their epiglottic opening. You're like, oh.
Yeah. Make some assessments of the people around you. Like, see, so you have a reference.
Now, I'll say it just right here. Like, anytime I'm transporting a patient, even if I'm not planning on intubating them, I will do a quick lemon on all of them, and that includes I'll just have them open their mouth to do a quick malampati. Obviously, I'll look external as well. And then, and you had mentioned...
I have them bite their upper lip.
Yeah, their lower jaw bite their upper lip, and that tells you about their range of motion with their jaw and how much you can displace that.
But I like, because most of my patients that are an inter-facility are still conscious. They might be sick, but they're still conscious, and I could walk them through that.
Yeah, a lot of the people you RSI, they can follow commands before you RSI them. And I would have to say, in my experience at my the fire department I work for, we have the big hospital in our city, so all our transports are short. So anything that can go wrong usually doesn't go wrong. But I learned very quickly on air transport specifically, but these longer transports, anything that can go wrong tends to go wrong. And so always, anyone you're transporting, it's a good idea, even if you're not planning on intubate, just do a quick assessment of their airway now and know what you're up against if things do go south.
I agree. And our next part of the mnemonic, not to just keep circling back to this.
Not going to say anything.
But obstruction or obesity, and it is a thing. It will...
She actually looks very kind.
I'm sure she is. This is very similar to...
I want to give her a hug.
My very first intubation in the field, it was a woman probably this size, and her chin turned into her chest. It was like Jabba the Hutt, and I remember being like, this is my first one. like this is going to be horrible. And she actually wasn't hard, which I, in my head, thought she's going to be really hard, but she wasn't. But obesity, I have a couple of examples, and especially obstruction. So if you've never seen a goiter, this is a pretty pronounced goiter. Wow. Like, she looks like she's wearing, or she swallowed a small animal or something.
Or a mango.
I don't know. This is why we use iodized salt. So everyone,
it's true.
It's not a bad thing to take your iodized salt. Anyway, that could be a problem managing her airway. I would definitely assess her. If I was picking her up for an inter-facility, she's going to get all the assessments, because I do not want... Can you imagine criking this patient? Like, that's going to be...
It would be a completely luck.
It would be so hard. So just have your assessment.
All the vasculature that must be involved in that. Like,
right. When you get a thyroid, it's not just like an empty tumor, or it's... Right. You're gonna have some obstacles to overcome.
That looks like Fat the Rock. Is it?
This was not AI.
Okay.
So again,
he really let himself go.
If you went, and this was your patient, and he's like, I'm feeling like I can't breathe. You're gonna have a lot to overcome to manage his airway. You cannot position him. His neck is not mobile. His tissue on his chin and his neck is going to make things very difficult to move tissue out of the way. I don't know what the inside of his mouth looks like, but just on first glance, I feel like this patient's going to be a difficult airway.
I guess you don't have I have it in one of my lectures, but it's Cosmo. This is a violation of HIPAA, but I'm going to do it anyways. Cosmo.
They might not know who that is.
Well, Cosmo the cougar. He's BYU's mascot. However, it's not always the same person.
It's different people.
Yeah, he was doing a stunt and injured his face. Basically, hit the rim. He was getting towed in on rollerblades, and then went off a ramp and then went to dunk. But instead,
there's video of this.
I have video of it.
We should insert it.
Yeah, maybe we'll insert it. And anyways, he his neck, like he broke his jaw, his neck was swelling, and
He hit it on the front.
yeah, he went face first into the rim right on his chin, but he had a big hematoma on his neck that was starting to compress his airway, and that was our biggest concern. And we got to the ER, and they watched it closely, took some X-rays, and they were on the border of going to keep him in the ICU in case it got worse, but they ended up it stopped. It didn't get worse, and they didn't end up having to intubate him. But yeah, facial trauma like that can make a big difference.
Yeah,
swelling.
that is. So, and then the N is neck mobility. Some of that applies to our obese patients, but we're looking at kyphosis or anything that might prevent them from lifting their head or moving their head back. This gentleman, you can see he's standing upright, but he is angulated forward at his neck, and it's not because he's just slouching. He
or
can't
sad.
he can't stand up straight.
He's sad.
We see this a lot. Our patients that they lose that musculature and they get that curve right at their neck, and they call it a head drop. They cannot lift their head anymore, and this becomes kind of frozen like that after time. So this is a bad story, Josh. We had a CPR call on a gentleman very similar to this. And as we arrived and the initial crew was doing CPR, his head was just on the ground, because every time they would compress him,
He'd roll back like a
roll
boat
back,
on waves.
and then his head would pop back up to its position that's like this in this picture. And that was, we very quickly were like, get some blankets under his head.
You get Ross, but now he's got traumatic brain injury.
I know. Well, it was Rusk. It was Rusk, but it was like, oh my gosh, we could hear his head banging against the ground. He was a head banger. It was horrible. It was horrible. So just know neck mobility is a consideration, and you're going to need to manage that. And I didn't put trauma in here, but that if we have a trauma patient in a C-collar, that is going to affect the mobility they have of their neck. And you're going to have to be cautious about that, because you can inadvertently displace their neck while you're intubating. On to the next acronym. It's RODS, and this means they're going to have difficulty with extraglottic devices. So this is like our iGel. The first thing, and the only thing I put a picture in here for was just restricted mouth opening. If they cannot open their mouth very big, you're not going to be able to get that device in there like you should. And this would apply also if you assess the 3-3-2 rule. They would not be able to fit 3 fingers in. And people have restricted mouth opening for lots of different reasons, but that's going to be a problem. Obstruction of the upper airway or larynx. Remember,
that's in all of them.
This is going to just sit. This device just sits over the glottic opening, so it's not going to fix an obstruction. Distorted or disrupted airway, if they've had radiation, if the tissue isn't soft and pliable, if they've got scarring, or even like that trauma you just described where they've got a huge hematoma that changes the shape potentially of their glottic opening. These devices are meant to sit against a normal and anatomical glottic opening. So that would cause problems. Stiff lungs requiring increased stiff lungs requiring increased ventilatory pressures. This is what we talked about when we mentioned those, that you can pop it off the glottic opening, not even realizing it. Like if you're BVMing and it's just like, oh yeah, and you're not watching for chest rise, you might not realize you've dislodged it. Any of our conditions that require higher pressures.
Potentially, you could also still have capnography waveform.
Yeah, because it's still there in their oral pharynx.
Yeah.
So just be super aware of that. This is where I say
hypopharynx.
Thank you. This is not someone we put on BVMing, like our police officer with no training, our brand new basic EMT. Running the bag valve mask needs to be someone who's familiar with what it should feel like, how we should put air in, and what we're looking for as far as feedback. Those are things that require skill, and so maybe not just a lay person or our brand new person. I would add to this, I know it's not part of this, but I've had personal experience with extraglottic devices and secretions. If you've got a super bloody or a contaminated airway with other secretions, I've found personally that they don't hold their seal as well, and that's just one of the things that I would just throw in there. Like, consider that if you do have a lot of secretions, you've got to really decontaminate it to get that extraglottic device to actually take seat and hold. Otherwise, you might need to consider a different option. So our last mnemonic is SMART. It's for difficult cricothyrotomy. There is another one that's very similar, and it's short. The acronyms account for the same things. The one from the Walls manual is SMART, so that's why we went with this one. But what you're looking for here is, have they had surgery on their neck? Do they have a midline neck scar that shows they've had some sort of surgery? That could change their anatomy to where you're not going to be able to landmark. Do they have a mass like our lady in the picture earlier with her giant goiter? Like, that's going to create issues, mostly with you landmarking appropriately. Will you be able to have access? Do they have a brace or a C-collar on? Also, anatomy. Remember, what did you said he looked like the Rock? The guy with
Fat Rock.
That guy, you're going to have to get through all of that tissue to access the cricothyroid membrane. And it's not going to be so fast. I think that's the biggest myth out there, is that it's just super fast, like super quick. Like, you typically...
Yeah, we've heard people who have never done it or even done it on a cadaver
and
talk
they think
about
it's
how,
like, click, click, click.
Scalpel, bougie, finger.
Yes. And I would love it if that...
Scalpel, finger, bougie.
And I've assisted with a crike. Like, that's the thing. You will likely go a career and not need to do a crike, because it doesn't present itself very commonly.
Fortunately.
Right. But the one that I assisted with was a physician, and that was performing the procedure. And even that was, he was methodical in his approach, and he was very careful to assure placement properly. And I think that's something as providers we should do. We're not just shooting from the hip. We need to go through proper steps. Radiation therapy, we talked about how that would change the tissue integrity. It would be harder to feel your landmarks, harder to cut through the tissue. Tumor, again, that's something that could be encroaching your airway that you might not have access like you thought you did.
In Boston, they don't have this radiation problems. They don't do the SMART algorithm. They do the SMART algorithm over there, huh? Smart, wicked smart.
Wicked smart. Okay. In managing the anatomically difficult airway, we are concerned with three primary axes of the airway, and it's the oral axes, the laryngeal axes, and the pharyngeal axes. And this diagram shows you kind of some different ways that they align. The first one on the top left is the head just in a neutral position, like you're laying on a flat bed. And you can see those axes are not at all aligned. And depending on what we're using for intubation, whether it's a video, hyperangulated, or direct, those are all going to change. We want to align them in a certain way. The head elevated position, just by lifting the head up a little bit on, a little folded blanket or a stack of blankets, you can align your pharyngeal and your laryngeal axis right there. And if you are looking around with a hyperangulated blade, there you go. It lines it right up. And then the bottom left is what we want for a direct laryngoscopy.
Or all three
They're
need to be lined
all
up.
as aligned as possible.
Yeah.
And so their head is up, but they are also in what we call sniffing the morning air. That's what they call that position.
Oh, yeah?
Yeah, it's like a sniffing. So there's
Sniffing the morning air.
you can kind of see the difference, how his head is slightly tipped. If you look at the angle of his nose, it just opens and lines those up. So if we're going to use direct laryngoscopy, consider putting them in this position. Now, another, sniffing the morning air is one reference that I've heard it called, but most commonly ear to sternal notch, meaning there's a line from
tragus.
Yeah, the tragus to the sternal notch.
Which is that little bump
that little
that sticks up towards your canal.
It's right in line with your ear canal.
Yeah.
So
that little fleshy part of your...
Some people get it pierced.
Oh, that's right.
Yeah, to help with migraines, I've heard.
Really?
That's what I've heard. I don't know. But that is a consideration. If I'm going into intubate someone who I know is down and I know like they're going to need airway management, I'm thinking ahead of time, because whether I'm using my hyperangulated blade or my direct,
just to be clear, hyperangulated is a blade that is common on a video scope.
Yes.
Video laryngoscopy.
Yes.
Versus DL, direct laryngoscopy, whether you've got a Mac or a Miller, you still have to get those aligned.
Aligned, yes. Now, the fourth one is also a hyperangulated blade situation. This one is almost always going to need a hyperangulated
The bottom
blade.
right, you're saying?
Yes, the bottom right. Because if you look at those axes, they're almost at a 90-degree angle.
Yeah.
They're very, which is what that's designed for. But I am going to take a folded blanket with me under my arm to manage that patient's elevation of their head. And that's an easy way to do that. If you don't have them on a gurney yet, I'm talking in a 911 scenario. If I've got them on the gurney, I can adjust the head of the gurney and move the patient toward me, and it makes it much easier to accomplish this.
All right, we're going to go ahead and stop there. This is going to turn into more parts than we originally thought.
Yeah, which I think it's appropriate because we need everyone's attention to last.
So go pee, get a drink, take a nap, and then come back to
get
part
some food.
Okay, thanks, guys.